So good morning. My name is Dobrucki, and thank you for the invitation to come here and give you a lecture. So let's start with this old painting by Rembrandt from the 17th century, The Anatomy of Lesson. And on purpose, I put as a first slide this painting because before the discovery of X-rays by Professor Röntgen in Germany, there was no tools actually to look inside non-invasively to the human body. And as the Rembrandt depicted very nicely, the anatomy lesson, so only the sections or autopsies, they've been only the tools that they've been available to look inside the body, but of course it was post-mortem. And we are trying actually to develop the non-invasive imaging strategies to monitor the progression of physiological processes and assess the efficacy of therapeutic interventions. And the final goal is actually to move those techniques to human patients to triage the patients, for example, from responders versus non-responders of the therapies. So let me first start with the basic definitions, what the molecular imaging is. So the concept of molecular imaging is in vivo characterization and measurement of biological processes at the cellular, molecular, whole organ and body level. And there are few requirements. So first you need to have some molecular probes which provides analytical signal. And the second is the method actually to monitor the probe. And it could be 2D or two-dimensional method or three-dimensional methods. Within those methods, we have direct and indirect target probe interactions or direct or indirect methods. So the first direct molecular nuclear imaging, the direct technique involves the probes that the magnitude of probe uptake and the localization are directly related to the targeted molecule. And the examples, historical examples, are, for example, native radio-labeled monoclonal antibodies used in the 70s last century, because they've been in use for some time, but then they had also very undesired effects, like a very long circulation time, which prohibited the imaging. So then the biologists and biochemists, they developed the engineered antibodies with the better imaging characteristics. And finally, the field went to developing the probes based on the peptides or peptidomimetic probes. And one disadvantage of this approach of the direct molecular imaging is that it requires the customized probe for every target of interest. So if you would like to image, let's say, some disease, so we need to develop the probe for this particular disease. Just to overcome this limitation, so they've been developed the techniques which involve indirect imaging. And one of those techniques is so-called reporter gene imaging. So the reporter gene is introduced by the viral or non-viral medium into the cell. And then it undergoes transcription and translation into the products of the gene, which could be a molecule, which is inside the cell, or it could be a receptor, or it could be a transporter type membrane. And then you need to inject just the generalized probe to the bloodstream, and this generalized probe can transverse the cell membrane and be enzymatically trapped within the cell, or it could bind to the receptor, or it could go through the transporter. So for this technique, we can have just one single generalized probe for imaging those different processes. And they are advantages. The enzymatic amplification of the probe signal that facilitates imaging the magnitude and location of reporter gene expression. The other advantage is that reporter gene product is produced only by living cells. So, for example, if you would like to track the cells, let's say stem cells in biological system, so the reporter gene technique is the method our choice because it tracks only living cells. And the reporter genes can be combined with a therapeutic gene. So then you can deliver some therapeutic gene to the single cell or to the target of interest. So let's talk a little bit about choosing the imaging technology. So the ultimate goal is actually to develop the high sensitivity and high resolution imaging systems and novel imaging modalities. The problem with that is that ideally it's not possible because in the modalities with a very high sensitivity we lack the resolution and vice versa. So we can have the modalities with a very ultra high resolution, but they lack sensitivity or penetration. So there is a table here which shows actually the clinical imaging modalities with some selected operational parameters. And I choose a couple of the most commonly used in clinics. So the couple nuclear imaging techniques like PET or SPECT, then the X-ray computed tomography, magnetic resonance, optical coherence, and the ultrasound. And you can see that there is a difference between the spatial resolution of those different techniques, the temporal resolution, sensitivity, penetration depth. So strictly, they are different techniques used in clinics, but they have strict advantages and disadvantages. And it depends on the application. You can choose which technique to use. So in my studies, for example, I'm using the nuclear techniques like PET or SPECT because they have very good sensitivity of the range of picomoles of the probes can be detected. The penetration depth is practically unlimited, so we can image big objects like humans or large animals. And the spatial resolution is a little bit lower than the other techniques, but it's still okay for the clinical approaches. And of course, I also use the X-ray computed tomography, and we'll be talking a little bit in a couple minutes, which has the very good spatial resolution. However, it lacks the sensitivity, so there is a lack of molecular probes for X-ray CT. So let me talk a little bit about the anatomy of CT imaging. So what's the CT imaging? So in general, in clinical systems, so we have the X-ray tube, which rotates around the patient with a very high speed. And there is a ring of detectors, this blue kind of rings detectors. They rotate around the patient. And the X-rays actually are emitted from the X-ray tube. And the penetration, it penetrates through the body. And the attenuated X-rays are collected by the detector. And then they are reconstructed in 3D space. So there are a couple advantages. So the absorption is proportional to concentration of contrast agent. It provides superior spatial resolution and temporal resolution in the clinical systems. However, there are some disadvantages. The main disadvantage is exposure to ionizing radiation, which could cause cancer, as you know. The other problem is that in many of those CT studies, the contrast agent is used, which causes the nephrotoxicity. And again, is very low sensitive technique. The other techniques to overcome the problem of ionizing radiation, they've been developed. So magnetic resonance imaging, it has a couple of the advantages. So the main advantage, there is no ionizing radiation, so it could be used multiple times in the same patient without any cause, any problem with the radiation exposure. It provides a superior spatial resolution, and the instrumentation is available in almost all hospitals. There are some disadvantages. So the technique is very sensitive to motion artifacts. Again, the contrast agent, which is used for contrast MR studies, is nephrotoxic. It has low sensitivity for molecular imaging and lacks molecular probes. And finally, there are nuclear techniques, which I'm using in my studies. So they are SPECT or PET. SPECT stands for the single photon emission computed tomography, and PET stands for the positron emission tomography. And they have very high sensitivity, actually, both techniques in picomolar range. The PET technique, which is shown over here, and the action, how works the PET scanner, I will show you in a few slides. But there are some established attenuation correction. The labeled trope, for example, for the PET imaging is structure identical to the parent compound. And it has some disadvantages. For example, PET requires the use of isotopes which are relatively short half-life. So, for example, there are some isotopes which have, for example, 2-minute half-life. So it means that we need to produce those isotopes on-site. Therefore, this technique requires on-site cyclotron in many cases. And that's why it's expensive. On the other hand, the SPEC technique, which was in the clinical world for at least a couple of decades, it has better spatial resolution, less than 1 millimeter. It is possible also to inject multiple isotopes in one object and image those multiple isotopes at once. And the gamma cameras, because it's very old technique, relatively old technique, are widely available. So let me talk about some operating principles. So the PET, which stands for positron emission tomography, is based on the emission of the positron from the unstable radioactive isotope atom. And this positron, which is the antimatter, it travels within the body, and then it annihilates with the electron in your body. And it's like a small kind of explosion. Of course, it doesn't damage your body, but it's annihilation. In the annihilation process, there are 2 photons generated at the distinct energy of 511 keV. They are separated by 180 degrees, and they hit the detector in the detector ring of the PET scanner. And then the computer actually calculates those detects those events, so-called events, and reconstruct in 3D space the image of those annihilation processes of those events. The SPEC technique is a little bit different. So SPEC stands for single photon emission computed tomography. So here we have a patient which was injected with a radioactive agent, and then we have a head, gamma camera head, which rotates around the patient. So within the PET there is no rotation. Within the SPEC there is a gamma head which rotates around the patient and collects so-called projection images like this, which are then reconstructed in 3D space. As I told you before, the advantage of SPECT, one of the advantages of SPECT is that we can use multiple isotopes. So these are the spectra, emission spectra of 2 very often used in clinics isotopes, the thallium-201 and technetium-99m. And you can see actually looking at the peaks of emission of the gamma rays, they are distinct energy maxima. So therefore we can inject to the same patient the thallium-201 isotope and technetium-99m isotopes and just do single scan using gamma head and separate the images based on those distinct energies. Well, so there are 2 things that we would like to measure using the molecular imaging. One is the function and one is the anatomy. So the function, actually we use the techniques like PET or SPECT. And especially for the cardiovascular system, so before we tried to measure some physiological consequences. So for example, the process of angiogenesis, which I will talk a little bit also later, is the formation of new vessels in different diseases or in some natural occurring process. And this angiogenesis changes the permeability, improves the perfusion, and improves the oxygenation. So therefore, we can actually detect the changes in hypoxia, changes in function, or change in metabolism, or pH. Therefore, the imaging of myocardial angiogenesis was to develop the non-invasive targeted imaging strategies, which will be critical for evaluating angiogenesis and assessing efficacy of angiogenic therapies in patients with chronic ischemia or following myocardial infarction. So I'd like to give you a typical workflow, how we develop and validate the new radiotracers, and then we'll go to multimodal agents. So there are three phases of the development and validation of radiotracers, or multiple modality tracers as well. So first there is a development phase that we need to identify molecular targets, synthesize molecular ligands, and we can label molecular ligands. And then we go to the in vitro validation phase. Then we check actually if the probe that we synthesize, what's the reception binding, what's the specificity, targeting efficiency, and radiotracer biotoxicity. And then after we went through this validation phase, so then we can inject the agent into the animal. But first we need to identify the animal model of disease and check some of the kinetics, like blood clearance of the new tracer by distribution studies. And finally, we can do some image acquisition. In case of nuclear techniques, SPECT or PET acquisition. So let me first go through the development phase. So first, what we need to do, we need to identify the potential targets. In my studies, I'm interested in imaging angiogenesis, which actually starts from the angiogenic factor production. It could be, for example, released by the tumor cells, or it could be due to the hypoxia or like heart infarct. So those angiogenic factors, for example, VEGF, which is the vascular endothelial growth factor, starts actually activation of endothelial cells, and those endothelial cells, they migrate and form the tubules, so small vessels, and then they mature, and we have some extra vessels or additional vessels which provide the blood to the tumor, or they can circumvent the hypoxic areas. As you can see here, so we identify multiple potential targets. Let's say VEGF receptor, which is the initial event for the stimulation of angiogenic process. There are some other receptors which are involved in the migration of the vessels and formation of tubules, like integrins alpha V beta 3 or alpha V beta 5. There are some matrix metalloproteinases which are also activated in this process, and there are also some, let's say, ephrins which differentiate the venous from arterial circulation. So when we identify those, so then we can start developing the agents. And these are actually the typical agents used or developed within the last 2 decades for both SPECT and PET imaging in tumor and the myocardial or peripheral limb angiogenesis. And they are targeted at VEGF, for example, receptor, or alpha V beta 3 integrin. So I'd like to give you some of the examples from my laboratory. So we've been developing and validating the new peptidomimetic quinolone, which is the alpha V beta 3 antagonist. So actually it binds to alpha V beta 3 integrins, which are activated in angiogenic process. So this is pretty sophisticated structure with a linker and also with the complexing agent, which complexes the indium-111, which is the radioactive isotope for the SPECT imaging. We also developed some other agents which have been alpha V beta 3 targeted with a different isotope, with the technetium-99M, which was based on the RGD peptides. So those peptides actually are specific to the alpha V beta 3 integrins, and they bind to activated integrins as well. So when we define the target and we develop some probes, so then we go to the next phase, the in vitro validation. So we check all those receptor binding, radiotracer specificity, targeting efficiency, and radiotracer biotoxicity. So with this alpha V beta 3 targeted quinolone, so actually we had the access to fluorescent analog, which was the TA145, and therefore in the HUVEC cells, so human endothelial cells, we've been labeling those cells with the antibody against alpha V beta 3 integrin, and also we've been staining those with the fluorescent analog of our radiotracer. And then we look at the colocalization. So we proved actually that the alpha V beta 3 integrins, they correlate very well with our probe. So it was good actually targeting. Then we also looked at specificity. So we had the RGD peptide and also some scrambled peptide, so GDF, which had different amino acids sequence. And we look actually that they are specific binding in endothelial cells with the RGD, but not the scrambled peptide. And then we went to the looking at the cellular specificity. So we would like actually to look whether the peptide, the developed agent or probe, binds to the cells that we would like to image, actually endothelial cells. And in this case, we have here the endothelial cells, staining of the canine infarcted heart. Then we had the fluorescent analog of our radiotracer, and we looked that there is a fairly good fusion with the endothelial cells. The CD14, it's actually the antibody against the macrophages, and we look some of the colocalization, but not complete colocalization. However, when we stain the tissue with the alpha V beta 3 integrin and with the fluorescent analog, so we look actually that there was a complete colocalization between alpha V beta 3 integrin and our probe within the tissues. Well, so we actually went through all those in vitro validation processes, and then we tried to identify animal model of disease and do some initial studies. Well, so we developed a couple of the experimental models, animal models. And I will talk a little bit shortly about all of them. So we had some mice model of infarction, the rat model of infarction, and also the canine model of infarction. And we talked a bit about the murine model of infarction. So it was the surgical model. So the mice were surgically operated, and the ligation was placed in the coronary artery just to block the flow in the heart. And actually what you see here is the infarct, very, very profoundly seen here in the short axis sections. So all this actually is the infarct, and this is the healthy tissue. If you compare to the control, so you can see also the increase in the heart size. So we've been imaging those with our agent targeted alpha V beta 3 integrin, and also with the agent which shows the perfusion in the heart. So the typical perfusion of the healthy heart looks like a donut shape, like this. And this is actually in the basal slice of the heart of the wild type mice. However, if we have the infarct, which was in more apical sections, so we see this defect in the perfusion. So this actually corresponds to the infarcted tissue. And this infarcted tissue was undergoing the process of angiogenesis, which was shown here, and much more profound in the other type of mice, the knockouts mice, which had enhanced angiogenesis. So these have been our initial studies in mice. And then, of course, after imaging, we cut out the hearts sectioned into 4 different pies, each section. And then we measured the activity in each of the sections using the gamma well counter. What is shown here is the circumferential plot of those all sections. So in the areas where we have lower perfusion, shown here, but this decrease in the green graph, we observe the increase in the uptake of our radiotracer. We could also quantify it and shown actually the differential uptake of our radiotracer in two different groups of mice. So with those studies, we kind of proved that the concept of molecular imaging using this modality probes was working well. Then we went to the rodent model of MI. So again, it was by surgical ligation of the femoral of the coronary artery to create the infarct, which was shown here. We confirmed this also by the echosonography. So this is the control non-infarcted animal. So there is a good systolic and systolic and diastolic phase. And here actually we have some problem with the contraction of the heart due to the infarct. And we've been able to look at the process of angiogenesis in the infarcted rat hearts as well. Shown here is the cardiac SPECT CT imaging of the angiogenesis in the heart. So again, similar to this what you've seen in the mouse. So the lack of the perfusion in the heart corresponded to the uptake of our radiotracer, which shown actually the process of angiogenesis in the heart. So we've been also doing some quantification. But I would like to go to the canine model of infarction. So we did this by the balloon angioplasty. So this is the typical catheter with a balloon, which is used for the placing the stents, for example, in human coronary arteries. But in this case, we inflated the balloon and kept this for about 1 hour or 2 hours. And then we actually occluded the coronary tree, causing the infarct, which was shown here by the thallium scan. So the defect in the thallium corresponded to the infarct in this area. So again, using our agents, so this was the indium 111 alpha V beta 3 targeted agent, we've been able to see the process of angiogenesis non-invasively in the living dog. And also we've been able to quantify those. So let me go to the anatomy now, because I showed the probes that have been used for studying the function or myocardial angiogenesis. But then what about the anatomy? So we have two techniques which we've been using in our studies, the computed tomography and also the MR imaging. And let me concentrate more on X-ray CT imaging, which I'm using in my studies. So the X-ray CT imaging exploits the differential attenuation of photons by different types of material in an imaging volume. And we very often use some X-ray contrast agents to increase this attenuation or just to increase the contrast in the image. So there are a couple of the iodinated contrast agents, which is very often used in clinics. Again, the OmniPack, which was marketed by GE Healthcare. But there are also some preclinical contrast agents like Fenestra. There are also some gadolinium-based contrast agents used for both MR and CT. And there are some barium bismuth sulfate-based contrast for postmortem imaging. And finally, there are some recent groups of nanoparticles, the gold nanoparticles for CT imaging. Let me just browse through a couple of the examples. So the OmniPack, which is the iohexol, is the non-ionic water-soluble radiographic contrast medium, which has actually a lot of iodines. So the iodine content in the iohexol is about 46% of its mass. So it's very good, provides very good contrast ratio. It's FDA approved, so it's used in humans very often. It's relatively inexpensive for a single study. However, it has very low blood residence. So actually, in patients, when there is a process, where is the imaging technique called coronography, so using inserted the catheter into the left coronary 3, there is a bolus injection of the contrast, and then within a couple seconds it actually goes to the kidneys. So it's very hard actually to do some longitudinal studies using this contrast. And it also has some nephrotoxic effects. However, we've been able to use this agent to successfully image the myocardium of the rat, for example. So this is the typical rat slice with the infarct over here. And we've been able to look at the left ventricle and right ventricle using just single bolus injection with the iohexol. However, the problem was that if you would like to do some functional studies using CT, so we needed another agent. And another agent, the Fenestra VC, which was marketed by the ART Technologies, it provides actually a very good residence time. So it was still present in the vasculature for up to 4 hours post-injection. However, it was very expensive, about $60 per mouse. But with this agent, we've been able to do those kind of imaging. So this is the mouse micro CT imaging gated with the ECG signal. So we have here 8 different phases of the cardiac cycle, and we've been able to image those at different sections and calculate the function of the heart. There is another agents which are used for the postmortem imaging. So this is the emulsion of the barium and bismuth sulfates. And unfortunately, it's only used for postmortem imaging because it involves the injection of the agent for visualization of the vascular tree, like here in the mouse. But serial imaging is not possible because the animal is imaged postmortem. So let me maybe browse through the next one. So the gold nanoparticles, there was recent development in the nanoparticles that are also visible by CT technique. So it has the gold the gold core with some protective layer, and there is soluble biocompatible layer. And it provides very good imaging characteristics. So for example here, our initial study, so this is the CT image of the mouse before the injection of the contrast. So actually you can see some anatomy, but unfortunately if you are interested in imaging the heart, you cannot see any structure of the heart. But after injection of the agent, you've been able to see the vessels, you've been able to see the atria, and also the left or right ventricles. It was very good imaging. The problem was with the blood residence time. So 1 minute after injection was still kind of good residence of the agent of those nanoparticles. However, after 10 minutes or 20 minutes, it was almost impossible to distinguish any structures in the heart. So therefore, we've been studying or trying to develop some new agents used for CT imaging, which had the increased blood residence time. So this we can achieve by so-called pegylation process. So we've been able to attach to our gold nanoparticles the PEG, which improves the blood residence time. And these are some examples. So at Yale University, where I worked a couple months before, so we've been developing the gold nanoparticles with those PEGs, branches within 100 to 200 nanometers in size, and it actually increased the blood residence time. As you can see here, so about 2 hours post-injection, so we've been still able to see the structures of the heart. It was not very great intensity, but it was, again, 2 hours post-injection. So what are the possible applications of the CT imaging? So first, what we can do if we have the single ungated micro CTs, so we can do the anatomical visualization of the heart, for example, or other organs. So we can calculate, for example, left ventricle versus right ventricle size and mass to assess the function of the heart. We can also do some ECG-gated micro-CTs, for example, for the strain calculations of myocardial function. But the final goal is actually to go to hybrid imaging. And this couple slides, I will conclude the lecture today. So the hybrid imaging is actually the combination of two or more imaging modalities. So I show you some examples of functional imaging and anatomical imaging. But what if we would like to do everything using the same probe, single probe? So in routine clinical practice, we have actually the SPECT-CT or PET-CT scanners. So they actually combine those techniques, the SPECT nuclear and CT for anatomical imaging. So both, they provide very high sensitivity using the nuclear techniques and also very high resolution of X-ray CT. So this is the final goal actually which we would like to achieve. And there are also some novel hybrid instrumentations, for example, combination of the nuclear techniques with the MRI imaging. So in my lab, actually, we've been developing some agents for multifunctional imaging and multi-modality imaging, and we concentrated on the group of nanoparticles called dendrimers. And the dendrimers, there is a branch structure, macro molecules, which are highly functionalized, and they have some very good advantages for imaging. So, for example, they have very rapid cellular entry, reduced macrophage uptake. It's very easy to put the targets on those branches. They are multivalent, so we can add multiple targets and multiple labels on the dendrimers. And they also have better passage through biological barriers by transcytosis. They also are kind of interesting because the different size of those nanoparticles preclude actually so-called passive uptake. So some of those so-called generations of dendrimers, they provide different passive uptake. So for example, with the low generation particles or dendrimers, we can image the vasculature, or with the higher generation particles, we can image liver, for example, or other organs. So again, this is the passive targeting, so we can actually do some targeting by changing the size of those nanoparticles, but also we can apply some targets on the functionalized surface of the nanoparticles for the active targeting. And I would like to give you some examples. So there's the group from WashU which developed some nanoparticles based on dendrimers, and they've been targeting actually the process of angiogenesis in the murine model of hind limb ischemia. So they had some non-targeted nanoprobes injected, and this is our ischemic leg of the mouse. So there is no specific uptake, but within the targeted probe, we have some increased uptake in the ischemic leg. But again, this is single modality imaging. So in our lab, we've been first developing the dendrimers as multimodal perfusion agents. So there was no targeting. So this is the typical branching structure of the dendrimers, highly functionalized, and we've been able to attach the label, radioactive label, on a couple of those branches. And the rest of those we filled with the triiodobenzoic acid, which is the source of iodine for X-ray CT imaging. And in initial studies, we've been doing the CT imaging with the dendrimer samples and also corresponding OmniPack samples as a gold standard for the CT contrast CT imaging. And we've been able to see pretty good linear correlation between those two. So what about the serial X-ray imaging? So what's the blood residence time? It was also very good. So this is the image before the injection, and 5, 10, 20, and 1 hour after injection of the dendrimer nanoparticle. So we still been able to see the structure of the heart, right and left ventricle. And because we've been able to label those nanoparticles, so then we developed the agent, which was the multimodal. So we've been able to do the perfusion studies using the CT. So again, you can observe or appreciate the structure of the heart, but also using nuclear techniques, we've been able also to see those structure and also do some functional assessment. But again, it was non-targeted dendrimer nanoparticles. Again, we've been also able to see the vessels, like here. But then finally, we added also some targets. So some of the branches were labeled or bioconjugated with a cyclic RGD, which targets alpha V beta 3 integrin. And then we did a study with 3 different groups. So the group number 2 was alpha V beta 3 integrin targeted peptide, and 2 of those were scrambled peptides or control groups. And we injected this to 3 different animals, which had the ligated femoral artery, which was shown here, which after 2 weeks actually shows some formation of collateral circulation in the leg, which is the process of angiogenesis. So we did initial biodistribution studies using those nanoparticles, and we've been able to see that most of those nanoparticles are excreted by the kidneys. What about the targeting? Well, so this is our RGD or targeted dendrimer. So we've been able to see the specific uptake of our agent in the ischemic leg, but the control agents actually did not have this uptake visible, which was also confirmed by the image analysis. So distal leg actually with the cyclic RGD, so targeted dendrimer, shown the specific uptake, but not the control ones. Also, I would like to conclude this lecture with a final slide, because in my opinion, the multimodal agents, they require actually the access to multidisciplinary teams, because we need the engineer which developed the technology. We also need the chemists which develop the tracer agents. We need also physiologists which they develop some animal models, and then pharmacologists which develop the new therapies. And all this we can actually apply for our multimodal, multifunctional imaging. If you have any questions, I'll be happy to answer.
Thank you. Great overview.
So, thank you for the question. So again, I showed just only the type of nanoparticles, the dendrimer nanoparticles, and as you will see probably from Dr. Boppart's lecture, there are multiple other nanoparticles that can be used, different techniques. But it's beyond this, 1 hour lecture to show you all different nanoparticles. I on purpose actually concentrated on the dendrimer nanoparticles because first they are available already for human imaging, which I'm also interested in. So we can do some preclinical imaging in small animals, go to the larger animals, and then because they are FDA approved, so then we can go to the human studies. That's the first one. The second, the dendrimers, as you can see, they are highly branched nanoparticles. So they are also very easily to modify the surface of the nanoparticles. So we can add multiple targets, we can add multiple isotopes, we can do even triple modality or multiple modality agents using just the dendrimers. And you ask about the gold nanoparticles. Well, they are different again, different nanoparticles with the gold core. There are some iron core or iron oxide core for MR imaging. So it depends on the application or your expertise, which you would like to use. I don't know if I answered your question. Yep. Yes.
Do you think it can move to clinics, and how is it reversible? After the disease cure, it goes back to normal.
Well, so for a couple years ago, the gene therapy was kind of a very promising therapy. Same like right now is the stem cell therapy. So, but it's only my honest opinion, but I think we don't understand too much how it works to be successfully used in humans. So there are some genetic therapies already used in humans, but I will tell you with the initial interest in stem cells, that it can cure any disease, it's kind of right now diminished because we don't understand how the stem cells differentiate in the human body. And there are some examples of the therapies which actually went very badly. So after injection of stem cells, the patient developed the cancer because those cells then differentiated in cancer cells, but not those cells that they wanted to be differentiated.
What application they use in
So there are some initial, but I don't think they are kind of like very widely available, but there are some gene therapies used to induce the angiogenic process in the, let's say, diabetic patients, which suffer from the decreased circulation in the peripheral. So there are some viral agents which encode the vascular endothelial growth factor, which could be injected to the humans, and then those viruses, they produce vascular endothelial growth factor just to improve the function. And they've been, for last, I would say, 15 years, they've been a couple of the clinical trials which showed actually very low benefit ratio. So they've been some improvement, but not as much as shown in the preclinical imaging, in the clinical studies in animals. Yeah.
My question was related to the appearance of the nanoparticles. Can you comment with regards to size, targeting, and the site of injection? Like how does each of these affect the appearance of dendrimers or those nanoparticles?
So the first question is about the size, right? So first, as I shown in one of the slides, there is so-called passive targeting of the nanoparticles. So you can see differential uptake of the nanoparticles that it depends actually on the size. So smaller size nanoparticles, they tend actually to go to the, I would say, to the holes between the endothelial cells that they can be trapped within the intracellular space. And the larger nanoparticles, for example, they can kind of be much longer resident in the vasculature. So that's why within the targeting, for example, we would like, so again, for targeted imaging, very important is to have long residence time, but not too long, because the goal of it is that there will be enough residence time of nanoparticles to actually bind to the target of your interest, but also you would like to remove the unbound nanoparticles from the bloodstream just to have better image quality. So that's why the initial studies with the just antibodies labeled with radioactive or magnetic resonance probes, they've been not so well received because the antibodies, they travel, they circulate in the bloodstream for a very long time, for days. So that's why there was a lot of background which kind of prohibits from, quantification of the images, or the quality of images was not very good.
And the site of the injection site?
On the site of the injection, so we try always to inject into bloodstream. So I don't know what you mean by.
I mean, if you do tail vein injection versus injecting close to where you want your particle to actually go, would that prevent clearance?
So in most of the studies, we try to inject to the systematic circulation. So it could be through the tail vein injection if you are good in tail vein injection technique, because there is also like some operators, they can inject probably 80% of the dose into the tail vein, or sometimes it's not successful. So if you'd like to quantify some images, and so you need to know the dose to be injected, right? So if your injection is not successful, or it's just only 80% of injection was successful, so then the quantification can be problematic. And there are some studies that, personally, I've seen some studies, they've been injected, the agents were injected not in the bloodstream, but IP, for example. But again, it requires much longer time for the distribution of those nanoparticles. So I think the bloodstream is the best.
And also, as you mentioned that the Dendrimers are FDA approved, are they FDA approved for a certain size, or are they?
Well, so it was probably too general. So FDA approved, there have been some compounds based on dendrimer structure. They've been approved by FDA for the human use. So it's not like all dendrimers are approved, but because the structure of dendrimer is known and the toxicology is already known, so the process from developing the dendrimer nanoparticle to the process of approving for human use, it's much shorter than developing from de novo. Yes.
Longer reference time, how do we improve the spatial resolution, and how long does it take to collect the sample?
So spatial resolution doesn't depend on the probe. So spatial resolution depends on the instrumentation that you use or technique. So that's why, so in multimodal agents, the beauty of this is that you can apply, for example, if you are interested in spatial, very good high resolution, spatial resolution, so you should use techniques which provides this very high spatial resolution, like CT, MR. But if you are interested in sensitivity, for example, so you should go to nuclear techniques or optical techniques.
How long does it take to collect the sample?
Excuse me?
How long does it take to collect the sample?
How long it takes to detect the sample? Again, it depends on the technology. So for CT imaging, for example, we can do the single scan within a minute or 2 minutes. With the nuclear techniques, it could be from 15 minutes to 1 hour. It depends on the protocol. Yes, so this is actually one of the examples at the very end of the lecture, that you can also do targeted imaging with the dendrimers. So it's very easy to conjugate some antibodies or targeted moiety to the dendrimer nanoparticle and do the targeted imaging in addition to the passive uptake. Yeah, so for example, if you're interested in vascular imaging only, okay, so you would like to image some epitopes which are expressed on the vasculature. So the method to go, it will be to choose the dendrimer generation or the size of the dendrimer which gives you the best vascular imaging possible. So it will probably go with the lower generation dendrimers. And then you can target those dendrimers with those which will target the epitopes of interest. So for example, if you'd like to image, let's say, angiogenic process in the vessels, right? Or let's say atherosclerotic changes or atherosclerotic plaques. So you need to conjugate actually the target, which will bind to the epitope expressed on the vessel. Yeah, so it's possible and it's done. Yeah. So I don't think it's the question of stability. I think it's the question of the imaging characteristics. So the antibodies, because they are very sensitive, right? So the antibodies are very selective to the target or target of interest, much more than RGD, for example. The RGD peptides, they bind to integrins like alpha V beta 3, but they are also some binding to alpha V beta 5. But again, the antibodies, they circulate very long. And for example, for nuclear imaging, if you label the antibodies with short-lived isotope, so after it will clear from the bloodstream, so your isotope will decay. So you will not have possibility to detect this anymore. So that's why there are recent developments to develop the isotopes, like PET isotopes, which have very long half-life, let's say like 3 days half-life, and they are labeled with the antibodies. So the antibodies are labeled with those isotopes, and then the patient or the animal is injected first, and then 3 days later they are imaged, because 3 days later there is some specific uptake of the antibody, but there is also the good clearance from the blood.
Okay, great question.
All right, thank you.